Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. We are just a few weeks away from moving the first patients into the new WVU Medicine Children's Hospital, which includes centers of excellence like the Heart Center, where experts provide the state's most advanced cardiac services for infants, children, and teens. Today, we're talking with Dr. Christopher Mascio, Executive Director of the WVU Medicine Children's Heart Center, about the specialty heart care services the center offers. Welcome, Dr. Mascio, to Tuesday Talks.
Thanks, Mary. It's great to be here.
It's good to have you. Now, if you have any pediatric heart care questions, feel free to put them in the comment section below, and we'll try to answer them for you live. Okay, so this is an exciting time.
Very exciting,
We're
very exciting.
down to just the last few weeks here before we make the big move. So let's talk about the Children's Heart Center. I know that every year tens of thousands of babies are born with a heart problem, or they develop a heart problem as they grow. What's the mission of the WVU Medicine Children's Heart Center?
So the mission is to provide top-notch, excellent, lifelong care for these kids. And many of these children are diagnosed in fetal life, and they carry this diagnosis throughout their life. And so we care for them from, literally when they're a fetus all the way through age 40, age 50. We're still seeing some of these patients. So really it's a lifelong journey. And you really can't be in this business unless you provide top-notch, excellent care. And so that's what our mission is. And I'd like to think we do it with a caring touch also. I think our team does a great job at that.
That's great. That's great. So does the Heart Center bring all medical services and support services for children, all under one roof?
Yes, it does. So the idea of a heart center is that all of the different areas that are necessary to care for these children are under one roof. So pediatric perfusion, pediatric cardiac anesthesiology, pediatric cardiac intensive care, pediatric cardiology, pediatric heart surgery, of course, what I do. All of that is under one roof. We have a couple of meetings each day talking about patients. We have weekly meetings to coordinate care. So yes, it's many people really working together to take care of these complex kids.
Wow. And you're a native, right?
I am.
How's it feel to come home?
Yeah, it feels great. It feels great. It wasn't a huge transition for me to move from Philadelphia here. I've been here about 15 months, and I know my family's happy. So that's been great to see them a lot more frequently than I normally do. And really, we've come a long way. The Heart Center's come such a long way in 15 months. We've done approximately 180 cases.
Wow.
Everything from complex neonates, single ventricles they're called. Those are probably the most complex children that are born with just one pumping chamber.
Wow.
Those children require 3 operations in the first 2 or 3 years of life.
Wow.
And so we're doing those children, we're doing teenagers, adult congenital patients. That's on the surgical side, but we also offer EP services for children that have rhythm problems. So maybe they have a structurally normal heart. They don't need my services to close a hole or to patch an artery or something, but their rhythm is abnormal. We have an EP lab that's very active.
EP stands for?
Electrophysiology.
Okay.
Yeah,
Mm-hmm.
and so they can ablate rhythm problems. They can place pacemakers, and so that lab has been very active. We have a cardiac cath lab, and that's a specialized cardiologist that works through the arteries and veins in the leg normally to place valves, to plug abnormal vessels, to dilate vessels and things. So we're doing all those things. We've been able to really ramp this up and get to a very high level in a very short time.
I imagine there's a lot of demand for those services here too.
There is, and the nice thing is that if we don't have a program here, then the children of West Virginia and the surrounding area, they either get no care, they get bad care, or they have to travel. And so, we're surrounded by some really good programs, but it's really not necessary anymore for children of this state and this area to have to drive hours and hours and out of state to receive pediatric heart care, because we can do that right here.
Wow, that's great. Can you talk a little bit about your team at the Heart Center, about the experience and the level of technology that you're dealing with here?
Yeah, so like I said earlier, for instance, I can use an example of a patient of mine. So a patient of mine that I operate on that needs heart surgery, they will meet the anesthesiologist, the perfusionist is in the operating room. There's usually 8 to 10 people in the operating room for just one case.
Wow.
After that, they go to the intensive care unit, where we have a separate cardiac intensive care unit team that is separate from the pediatric intensive care unit team. Both are excellent, but we have a group of doctors that specialize in taking care of preoperative and also postoperative heart patients. And of course, throughout all of this, these patients are seeing their own pediatric cardiologist. And so
wow.
They're touching many practitioners. We have the latest and greatest cardiopulmonary bypass pumps, X-ray machines, cardiac MRI, cardiac CT scan, echocardiography, 3D echocardiography. So, like I said, I feel like I can look parents and other practitioners in the state in the eye and tell them there's truly not a drop-off between the care that I saw our team deliver when I was in Philadelphia, CHOP, to the care here. I think the care
wow.
is excellent here. And honestly, one thing I like about our program is that there's enough people that I feel the team isn't getting burned out. Some of them may disagree with me. But there's enough people that they're getting enough reps, if you will, or like at-bats.
Okay.
But it's not so big that, the children, when I bring a child to the ICU, I know that the nursing team there, the bedside nursing team, excellent team, and the doctors taking care of them there, they will have been working most of the week, or it's not like they're going to have a doctor that's coming on service for the first time in 3 months just because there's so many of them. And so there seems to be a nice balance here of just the right number that people have a life outside of the hospital, but they're also taking care of patients very frequently. They're not rusty. So it's a very specialized field that you need all these sort of toys, if you will, and bells and whistles, but
and we got them.
We do have them, absolutely.
Yeah,
absolutely.
So it sounds like it's kind of like big city medicine in a small town smaller town atmosphere. Is
Definitely.
that fair?
Yeah, I think that's fair. I think that the reality is that there's a lot of scrutiny in this business, and bad programs do not survive. So if the results are not good, if the care is poor, number one, patients and families pick up on this, and there's social media now, just like this,
right.
And people talk and people message, and if the care is not good, patients will not come. And also, my colleagues and I, we hold each other to a very high standard, and so the cardiologist and the intensivist, the anesthesiologist, the nurses, they demand excellence out of me, and we all demand excellence out of each other. And so the reality is that if there are too many weak links, the program just will not survive. But we have a great team, and we're doing really well.
That's great.
Yeah.
That's great. You do have a diverse amount of programs here. So what would you say are some of the more unique treatments or programs? Like, I mean, for example, you do offer many less invasive treatments.
We do, and that's mostly based in the cath lab, it involves, rather than myself opening the chest to put a pulmonary valve in, for instance, we now can place a pulmonary valve in the cath lab that involves going through the vein in the leg and deploying a valve, and so that saves a child having open heart surgery. And so we have there's a blood vessel that we are all born with, and in premature babies it often stays open. And so previously, 10-15 years ago, that was a surgical operation where in the smallest premature babies we would have to open the chest and tie off this blood vessel. Now that can be done in the cath lab on really, really small, really young babies. So that can, just a very small plug can be put in there. And so those are just two of the examples of the less invasive therapies that we offer.
Now, you talked a little bit about the specialized intensive care, because we have a pediatric intensive care unit. We have one that's just for heart patients, and the NICU too.
Right.
Those really are, I mean, like, all intensive care units aren't the same, you know?
Absolutely. And just to highlight a couple things on the cardiac side, so heart surgery has only successfully been done on children probably since the early 90s. That's when.
Really?
Yeah. I mean, so the death rate from the most complex operations, even in the mid-'80s, was probably 30 to 40%, which is extremely high, obviously.
Yeah.
So now, if you look at all babies that are having open heart surgery, the risk of them dying, if you count everybody, easy cases, hard cases, it's about 3%. And in the in the highest risk cases, it's probably 10 or 15%. But my point is that because now most kids are surviving the operation, a lot of the focus has become is sort of turning to how do we make their quality of life as good as we can. And so and that starts in the ICU right after their operation. And so to highlight some of the specialized things we do there, first of all, we have experienced bedside nurses that take care of these patients. So they don't, when they graduate nursing school, they don't just start right away taking care of heart patients. There's like an orientation. They have senior nurses there with them. So that's one thing. Number two, to sort of focus on quality of life. The brain is always at risk when you do heart surgery, or even if they go to the cath lab and have some of these less invasive things. And so there's always a risk of stroke when you have heart surgery, but fortunately that risk is extremely low. But we still look for it. So every newborn that has an operation in the first week of life, EEG monitors get placed on the head. And so we look at the brain waves because we know that some children can have silent seizures. And so it's just small things like this. We constantly monitor the oxygen level in the brain. And so these are just some of the things that we do to, I mean, of course we're worried about the heart. We're looking at the heart rhythm and the blood pressure, but we're really monitoring as many other organ systems as we can, because the idea is that we want these kids to have a great quality of life. We don't want to say, oh, well, they survived the operation, but their brain's not great, or they survived the operation and their kidney's not great. But so, the focus, of course, in the operating room and in the ICU primarily is on the heart, but we're also looking at all these other areas.
So that sounds like it's a combination of different things that got us from, a 30 to 40% death rate in the 80s to, it's like, well, now it's 3%. I mean, still, that seems like an incredibly short amount of time to make that much progress.
Right. And that's not just been in surgical care. A lot of it is, or most of it has been, I think, in the medical care, in the type of anesthetic that's used in the operating room, the type of heart-lung machine that's changed to make it safer for patients. These less invasive options in the cath lab, being able to ablate rhythm problems in the cath lab by our EP doctor, and then a lot of these things. And once the patient gets to the ICU, getting the breathing tube out faster. using less morphine and fentanyl and other narcotics. We try to use as little of that as possible. And so I think it's a combination of a lot of these things. I like to say that I think that we're doing great, but we are standing on the shoulders of all those that came before us. So it's it's fun to wave the flag and say, hey, things are going really well. But all of us owe a debt of gratitude to our colleagues that lived through the 70s and 80s and early 90s to learn a lot of these things and learn what was working and what wasn't.
Wow. What is your busiest program? I mean, we've got a whole list here of the different programs, but I mean, where are you seeing the most patients? Where's the greatest need?
I think it's interesting that you asked that. Just today we give sort of regular heart center updates, and today we had a heart center update, and we received an update on the volume of the program. And so really across the board, volumes are up. Surgical volume is way up. The number of neonates, that's babies less than 30 days old, basically newborns. In 2021, in the first 8 months, there were 4 of those done. This year, there's already been 15 to 20 done.
Wow.
Echocardiography, so that's a non-invasive way, that's a ultrasound of the heart, right? So we've done 400 to 500 more of those this year than we did last year.
That's a lot.
The cardiac cath lab has already done more cases this year in 8 months than they did in 12 months last year. The EP lab has done more rhythm procedures, just about as many rhythm procedures as they did last year in the first 8 months this year. Fetal echo numbers are way up. And so really, it's really just across the board. Our pediatric anesthesiologists are very busy now. They help out not only in the cath lab and the EP lab, in the operating room. They transport kids for CAT scan, for MRI, and so we're looking to hire a third anesthesiologist that does peds cardiac because of that. So it's really exploding quite a bit, and I think these programs take 2 to 3 years, 2 to 4 years to really know where things will level out, but it's really across the board. It's getting really busy.
The need and demand is there.
Absolutely.
Wow. So you're going to have to grow as quickly as the need and the demand.
Absolutely.
Which you're doing. But some of these other programs, like we were talking about a little bit, you touched on the pacemaker care program the Heart Center offers. Is there a lot of demand for that? I mean, I don't think of children with pacemakers, but I guess there are, huh?
There are. It's probably not the most common rhythm issue that children have. Certainly a heart operation can cause the need for a pacemaker, but we don't have a high rate of that at all. And there are other children born with a low heart rate that need a pacemaker. So mothers that have lupus, that's a sort of a famous diagnosis that their children are at risk for having heart block, it's called. That's when you have a slow heart rate, and so those children sometimes need pacemakers. And there are other children that can have a really fast heart rate or a slow heart rate for other reasons, other than lupus, that need a pacemaker. So it's not the most common rhythm abnormality that we see, but we offer that service. So both transvenous, where the leads for the pacemaker are placed through a vein, and the battery is sort of up here on the near the shoulder, and then other children, small children, need the pacemaker leads put directly on the heart, and that's something that I can do, until they're old enough to receive a transvenous one. But.
Wow. What about advanced heart and lung support?
No, that's a great question. So there are some hearts that are so weak that even if we use the highest level of the strongest medications, the muscle's just burned out. There's scar tissue, or it's just checked out. It just doesn't want to work anymore. And so then we have to start talking about advanced therapies. And so ECMO is a heart-lung machine that can be used at the bedside. It's a temporary heart-lung machine. There are some children that unfortunately get viruses, common cold viruses, and some kids are just not lucky, and it attacks their heart muscle and it makes it weak. many times that will get better, so they need ECMO for just a short period of time. And there are other heart pumps that I've put in plenty in the past, and we are in the process of really looking to add that program. That's really the one thing that we need to add over the next 1 to 2 years is what's called ventricular assist devices, or VADs, that and heart transplant. So, and the reason we haven't started that right in the beginning is that programs we need a couple of extra personnel, and then we need the team to get used to and familiar with a lot of these pumps. But our start has been so great and excellent and faster than I thought that it would be, that I think we're going to be able to offer those services sooner than later. I thought coming in we wouldn't be able to do heart transplant for 4 or 5 years, but we're actually starting the exploration into that and starting to jump through the hoops that we need to jump through to get to that, to get to that point.
So it's coming, isn't it?
It's coming. Yeah.
That's good to know. You did mention the single ventricle care and the heart, and you are a heart surgeon. What are the most common heart surgeries that you wind up doing on children and younger patients?
Yeah, so for the single ventricles, the Norwood operation, that is probably the most well-known single ventricle operation, and honestly, it's really a litmus test for a program. So a Norwood operation tests the surgeon's skill, it tests the anesthesiologist's skill, the perfusionist skill, it tests the cardiologist in diagnosing them, it tests the intensive care unit. They have very challenging physiology. And so it tests all of us at the Heart Center, can we take care of these patients? And so we've seen those patients here. They've done great, 100% survival so far.
Wow.
And with that particular operation, the Glenn operation is done when they're 3 to 4 months old, and then there's the last operation that the single ventricles receive is called the Fontan operation, and that's done between age 1.5 and 3 years. So they have 3 operations in the first 3 years of life. So it's a lot for the families, it's a lot for the patients. And one other plug I need to put in is that we have an excellent social worker, Brandy Davis, who just joined us in the last couple months, and she's been instrumental in being there for patients and families, helping families with gas cards, hotel discounts. I mean, these things are really challenging these days, and so, if you think about it, a patient that's in Beckley or Princeton to drive here, a couple tanks of gas, a hotel stay. So these are things that she's been able to apply for grants, and so she's able to give these patients gas cards, get them discounts at hotels, Ronald McDonald House stays, which are very, very cheap, and so that's also very important. We also, the primary focus, of course, is we need the patient to survive and have the best possible outcome, but we also need to take care of the families and the guardians, which I think that we're doing a great job at that too.
So you treat the patient and the families.
We do, yeah, and these are families that you get to know really for years and years and years. So
I'll bet. So why would you say patients, you mentioned earlier, you don't have to leave the state. You don't have to, drive somewhere far away to get really good care, really good heart care. So what would you say, why should patients come to the WVU Medicine Children's Heart Center as opposed to going somewhere else? I'm not naming names.
That's okay. No, there are a lot of choices, of course, but they should come here because I really, truly think that we just provide the best possible care for these patients. And I can look people in the eyes. I've been traveling the state from Martinsburg to Beckley to Parkersburg, the Northern Panhandle, Somersville, et cetera, and I can look at pediatricians and families and say that your child will receive the best possible care.
Yeah.
I'm doing the same operation I was doing when I was at CHOP, and I know that the anesthesiologist is giving the same care, the ICU, the cardiologist, the bedside nursing, the assistants that help me in the operating room, our PAs and our nurse practitioners. I mean, really, it's not, I just think of myself if my child needed something, and I would be asking these questions like, well, can you do this operation? And okay, maybe you can do it, but what if she has a problem at 2 in the morning? Is the person that's spending the night there, can they take care of this? And the answer is yes for this program, absolutely.
Wow, that's exciting. That's exciting. And now we're getting ready to move into this beautiful new building with even more assets. So I always like to ask before we go here, because I think it's about time we're going to need to wrap up here, but I always want to ask, what's the most important thing you want our viewers to know about the WVU Medicine Children's Heart Center?
I think I just want them to know that we are a fully functional, top-notch program that is running 100% right now, and that kids of the state and the surrounding area, they do not need to leave the state to get excellent care. And I feel even better saying that now than I did when I first came 15 months ago, because now we have 15 months worth of data that we can say, here you go, look at this. And there are parents out there that other parents can contact, and they can hear it from them. They don't have to hear it from me. So it's just top-notch, excellent care, and it's truly a team effort.
And 15 months isn't a lot of time.
It's
I
not.
mean, you couldn't have grown that fast if you weren't that good.
Well, like I said, it's, I would love to take all the credit, but I'm just a very small piece of the entire outfit, and it's truly a team effort. I mean, I can do the operation, but if there's not a cardiologist to diagnose it by echo, not an anesthesiologist to put them to sleep, wake them up, perfusionist, intensive care unit staff, it doesn't matter. And so it's truly a team sport, and I'm just happy to be a part of it, happy to sit at the table with the other leaders of the Heart Center, and really the leaders of WVU Medicine. They've been excellent and very supportive.
Okay, great. Well, thank you so much for sharing all this information about the Heart Center and about the different programs, and we'll be seeing you in a few weeks.
Thanks for having me. Thanks for having me. This has been great.
Thank you so much. Well, that brings us to the end of this edition of Tuesday Talks. If you're looking for more information about the WVU Medicine Children's Heart Center, visit wvukids.com. And join us next week on Tuesday Talks when we'll discuss the surgical and trauma services at the new WVU Medicine Children's Hospital with Dr. Federico Seafarth. I'm Mary Ravazio Menard, and on behalf of Dr. Mascio and everyone at WVU Medicine, thanks for joining us, and have a great rest of your day.